X-ray KUV and alpha. How do you prepare the patient X-ray KUV? No, that era has gone. When we were medical student, when we were house officer, we used to give what? The alpha is a trade name. We say that. Now we don't give because what they say is whether you prepare the bowel or not, sensitivity of detection is the same. So we don't do bowel preparation. So it's just a X-ray KUV. But we have to request as X-ray KUV because for the radiographer, the penetration, the amount of radiation that we use is different. Because in ideal X-ray KUV, the retroperitoneal structures should be seen. Kidney shadows, your source shadows should be seen. How is the X-ray KUV again? Kidney shadows and the source shadows should be seen for X-ray KUV. Kanchana is X-ray KUV at the X-ray KUV at the
मैं आ गया था डेविएशन में था
ये ना तो
ऐसे रेजेंट का चेक करता
X-ray KUV, you can see like this. X-ray KUV, source shadow should be seen, and the kidney shadow is also visible for X-ray KUV. Kidney shadow is seen against the peritoneal effect. So, if you take X-ray KUV of Chintaka and Lahiru, whose kidney will be seen properly? Chintaka, because he has more peritoneal effect, I assume. Because it stands out against the peritoneal effect. So those who have more peritoneal effect, the shadow will be seen better on X-ray than thin film. Okay. So that is X-ray KUV. Sensitivity of detection, sensitivity is around 60 to 80%. 60 to 80%. Venous stones. So those stones, 10%. Those stones 10%. Venous stone, 60 to 80% sensitivity. Any other investigation? Ultrasound T, what are the expected findings? What do you want to see in ultrasound T? Either presence of stone or indirect evidence of having stone. What are those indirect evidence? Dilated process of high ureter. So those are the things that you want to see. Okay? Ultrasound T. Any other investigation? So basic investigations, UFR, full gut count, renal profile, then you move on to imaging, X-ray KUV, ultrasound KUV, any other investigation. Let's say patient has microscopic hematuria, but X-ray KUV no stone to be seen. Typically, what is the next line investigation?
Cystoscope.
So, I will be Cystoscopic. Cystoscopic na gala pene.
CT.
What's it? Contrast CT or non-contrast? Non-contrast CT cave, NCCT cave. What is the sensitivity? 99%. 99%. Almost all the stones are seen on NCCT cave except drug-induced stones. Tell me a drug which can induce stones?
Methotrexate.
Indeedable. What is indeedable?
Antiviral.
Anyone taking indeedable? Anyone who's on indeedable at the moment?
Retro.
So drug given for HIV. Suresh is upset about the fact that he's not got it. So drug-induced stones are not seen on NCCKV, but all the others are 99% sensitive. CECT, contrast CT KV is also good. What is that? If you compare the contrast CT KB with non-contrast CT KB, what is the advantage of non-contrast CT KB? It's quick. You send the patient there within 10 seconds. You take like taking X-ray. Whereas contrast CT KB, you have to inject, and there are stages. You have to get the arterial phase, you have to get the renal phase, the game phases. So it takes time. Right? Time consuming, less time consuming. And what is the other main advantage? Huh? Yeah, the risk of contrast nephropathy is nil. The risk of contrast allergy is nil. So to compare those two, if you want to do investigation, LCCTV is investigation of choice. But in a patient where you want to see the get an idea of the excretory function also, then you have to go for contrast CT. Excretory function of the kidney. So that's as preliminary investigation, we most preliminary is X-ray and ultrasound. The next line is NCHCT. So that's how you investigate a patient with stone disease. I repeat, blood investigation, urine investigation, basic imaging, then NCCT or CECT. How do you manage stone disease? Who's your history partner? Yeah. How do you manage patient stone disease? You can manage them conservatively or you can manage them with interventions. And remember, there are patients with stone disease who require urgent interventions. You can't wait, they need urgent intervention. Who are the people who need urgent intervention with regards to stone disease? Yes, obstructed infected system. Obstructed, if there is a ureteric stone causing total obstruction and pyonephrosis. Obstructed infected system is an emergency. The more you keep, the more you get damaged nephrosis. So you have to decompress the system. That's one indication for urgent. Any other indication? Unilateral obstruction with single kidney. One side obstructed and patient has one kidney only. Urgent intervention. Or bilateral obstruction. They need urgent intervention. Bilateral obstruction, unilateral obstruction with single kidney, or obstructed infected systems are the three indications for urgent intervention. We keep that part aside. What are the elective? How do you manage? Let's say there are no urgent indications. What is the conservative management? What do you call that management? MET. What is MET? Medical expulsive therapy. Medical expulsive therapy. That is the management. Right? So stones less than 6 millimeters tend to pass spontaneously with your medical expulsive therapy. Fatality figures, if it is less than 4 millimeter stone, very small stone, 4 millimeter, the spontaneous passage rate with your MET is more than 90%. If it is 4 to 6 millimeters, it's about 50%. If it is more than 6 millimeters, it's about 10%. Right? Those who have small stones, we try to manage medical expulsive therapy. So medical expulsive therapy includes acute management with analgesics, hydration, so you have to ask them to drink plenty of water, and also exercise. Skipping is recommended. එහෙම කියලා skip කරන්න බැරි ඒගොල්ලෝ skip කරන්න කියලා ඒක හොම්බ කඩසම් සානලා කරගෙන skipping rope එක පැටලිලා වෙනවා. හරිද? Just to ask whether they can skip. I personally can't skip. Can you skip? You can. So recommended or jogging. What else? Medical drug accident, what is the lifestyle? Tamsulosin. Drug of choice is tamsulosin because it relaxes the smooth muscles, spontaneous passage is facilitated. Anything else? What other dietary advice? One of the conditions that I have to take out is
Moringa.
colic,
Moringa.
Any excess amount. You should not eat spinach like papaya. Papaya is a cartoon barna. Yeah, pick up and say. Repeat telecasting. So those are what are the recommended citrus fruit? What are recommended or not unknown? So that is your lifestyle modification and drugs and water and liquids and exercise. So with that, I told you figures. That is the continuous passage rate. But having said that, if the patient is persistently symptomatic, you have to intervene. Let's say, "Aani wai gala bili ita hatara, e ama nama abdomen pain hadaga nena." Nene hatara yoga sira angor kenna puluwa. What if he is in the 10% category? So if the patient is persistently symptomatic, despite of your MET, you have to intervene. What are the interventions? We have finished MET, now intervention. Intervention depends on several factors. Size of the stone, site of the stone, density of the stone, and lot of other patient factors and the facilities and expertise available. Size, site, density, patient factors, and facilities and expertise available. So we'll go by one by one. Kidney, renal pelvic stones. Have you seen stagnodes? Any large stone extending in 2 or more calyces or called stagnode. With a nice round stone in the renal pelvis, it will called a stagnode. Who's stagnode? Have you been to stagnites? Your word is not. So anything more than anything extending into more than 2 km is called stagnode. What are the common compositions of stone? Calcium phosphate, calcium oxalate, calcine stones, uric acid stones, triple phosphate stones, cystine stones. Who develops stone? What are the infections that can develop stones? Proteus and Klebsiella. Why?
The UBS speaking.
Because of the urinary alkalization. So those are the basics. So if it's a renal pelvic stone, what are the options available? So the option again can be divided into 3 categories. Number 1, non-invasive, then invasive. Invasive can be endourological, laparoscopic, open. Okay. First you divide into medical, surgical, medical or non-medical. Then intervention, medical therapy and intervention. Interventions can be non-invasive, invasive. Invasive can be endourological, laparoscopic or open. Okay. So what is the non-invasive category? ESWL, extracorporeal shockwave lithotripsy. Alien shockwave occurs after ESWL. Have you heard something like this? And we can use ESWL for pancreatic stones as well as for renal stones. So what are the complications of ESWL? Alien shock occurs after one is bleeding. But it is usually self-limiting. Question hematuria can that is bleeding, self-limiting. Take a infection. Especially if you break an infected stone, there is a risk of urosepsis. Third, pain. This patient has a large stone in the renal pelvis. ESW karna, body carrier karna. Why do they develop colics? Because when these small particles, when they pass through the ureter, so they develop post-ESW colics. And sometimes these broken small stone particles, they just stagnate one on another or on the ureter. That is called Steinstrasse. Just search X-ray. Steinstrasse, S-T-E-I-N. S-T-R-A-S-S. Straße. You will see X-ray, KUB, ESW දුන්නට පස්සේ කැඩිච්ච පොඩි ගල් කෑල්ලක ureteric එක polymer එකකින් හිටනවා. To prevent this complication, sometimes urologists put a stent prior to ESW to prevent that complication. So you can, one complication is bleeding, the other one is infection, the other one is pain. Those are the main complications. But there are contraindications as well. One is pregnancy. Obviously, if the patient is having a gravid uterus, you don't expose the patient to shock wave. One is aneurysms. Like patient has an abdominal aortic aneurysm or renal artery aneurysm, it's again contraindicated because that also can rupture. It was dark caddy, too many those who have bleeding disorders. One it can bleed, so if you subject a bleeding disorder patient into ESW, there is a risk of uncontrollable bleeding. So those are the contraindications. And ESW is ineffective for stones more than 1000 pounds per unit density. Stone density is measured in a unit called pounds per unit. HU. HU. Pounds per unit. So if the stone density is more than 1000, your ESW is ineffective. And from skin to stone distance is more than 10 centimeters. Please to remember, 1000, 10 centimeters. If it is more than 1000, ineffective. If it is skin to stone distance is more than 10 centimeters, it's again ineffective. For example, if Chintal gets a stone in the renal pelvis, may not be effective. Assuming he has skin to stone distance more than 10 centimeters. And stones that are in the lower part, anything below the mid-ureter is also ineffective. For those patients, we don't do ESW. So renal stones, is there a place for ESW? Provided it is less than 1000 pounds per unit. Provided patient is not morbidly obese. 3. Provided it is less than 2 centimeters. ESWL can be done. If the patient fulfills all the criteria, ESWL can be done for that. So one non-invasive treatment for renal stone is ESWL. So what are the invasive methods? You can't target ESWL because it's covered by a lot of bowels and all. You can't target it. What are the minimal invasive or endourological techniques? Have you been to GU theatre? At least once? Tomorrow is GU theatre, right? Tomorrow is GU theatre. GU theatre is theatre?
Yes.
Are there any patient admitted for PCNL? Just remember PCN, percutaneous nephroretinopathy. We can pass a scope from here, go to the stone and break the stone and take down. It's called PCNL, percutaneous nephroretinopathy. So what is percutaneous nephroretinopathy? Then what is the open or laparoscopic surgery? What do you call this pelvis? Medical term, pyelo. So to cut open to take the stone out is called lithotomy. So it's called pyelolithotomy. Right? So for renal stones, there are 3 options: ESWL, PCNL, laparoscopic or open pyelolithotomy. So those are the options available. So then we come to the ureter. What are the options available? Can we try medical expansion therapy? Yes. Can we try ESWL? Yes, if it's in the upper ureter, but anything below upper ureter is not. Right?
See, it's not. See, it's not confined here, but ineffective.
Can we try endourological technique? Yes, you can try. You can pass a ureteroscope and break the stones. How do you break the stones? You can use laser. You can use laser or you can use mechanical. When you go to theatre, you will see all these things. We use pneumatic wear, IPA, not Indian Premier League, intermittent pneumatic lithotripsy. Intermittent pneumatic lithotripsy, IPA. Or less, we break the stones and extract the stones out. That is that. Then can we try open surgery? Yes. What do you call that surgery? Ureterolithotomy. I told you cut open to take a stone out is lithotomy. It is done in the unit for ureterolithotomy. Open or laparoscopic ureterolithotomy. Then we come to bladder. Can we try medical expulsive therapy? Yes. What is the typical symptoms that patients complain when they have bladder next door?
Intermittent fasting, urine and then
Strangulate. Super and part to kill. Bladder empty way and neck started so what are the options are there? Can we try medical expulsion? Yes. Small, yes. Can we try ESW? Anatomical location is not compatible. Can we try endourological? Yes, we can pass a cystoscope and break it. That is called lithopaxy. Lithopaxy. Just even if you don't remember, endourological can be tried here. Then open. We don't do laparoscopy for bladder. Open. Bladder is called vesicle. It's called vesicle lithotomy. Very easy to remember.
so ureteric stones we can use cystoscope.
For ureteric, there are ureteroscope. First we start with the cystoscope, go to the bladder, then we with another tiny scope, we go into the ureter. That's it. Okay? So these are the options available. If a patient comes with obstructive infective system, let's say this patient, that's why I told you it's important to ask. Typical is like this. Patient also complains of fever with chills and loss of appetite. The diabetic patient, on examination, there is renal anger tendencies. What is your first impression? A patient, 70-year-old patient coming with irritated physical history, with associated with loss of weight, loss of appetite, not loss of weight, loss of appetite, fever, with chills, and patient is diabetic. What do you your working diagnosis? Pyelonephritis. So how do you manage the patient? Apart from your painkillers, you take blood for culture and ABST, urine for culture and ABST, start the patient on 11th antibiotic. Next day you do a scan. Scan says there is a hydronephrosis and hydroureter on the left side with the edematous kidney. Clinically compatible with pyelonephritis. What will you do? You continue your antibiotics. But on day 3-4, patient develop high spiking fever despite of your antibiotic. What are your possibilities now?
Abscess.
What are your possibilities now?
Abscess.
One is suppuration, pyelonephrosis. Anything else? Your antibiotic is resistant. Those are your possibilities. You can also repeat the scan. If it is suggestive of pyelonephrosis, what can you do? So there is a stone blocking the lower ureter, above which there is infected urine leading to pyelonephrosis. How do you manage that? Great. Management of pus collection is by drainage. So how do you drain this? You can put a percutaneous nephrostomy. Provided they have hydronephrosis also, you can put a percutaneous nephrostomy and drain the pus out. Right? Patient is settled. Any other? Can you do the same thing from below? Yeah, you can put a cystoscope and put a ureteric stent, bypassing the stone. Just the way you put a stent for biliary obstruction, with stone, so you can put a stent. So these are the two ways. Remember, we don't try to deal with the stone at this situation because this is a compromised patient, septic patient, obstructed infected system, ureter is inflamed. If you try to break the stones and break the stone out, we are going to cause more damage to the ureter. Therefore, we don't deal with the stone now. So we are just going to drain the system either by PCA for the nephrostomy or by ureteric stent. So once the patient clinical status settles, you can try all the other options that we described to deal with the stone. So that's how you manage the patient with obstructive infectious system. Okay. Clear? Any questions with regards to stone disease? And one more point, I forgot, with regard to investigation. If a young patient coming with bilateral stones or recurrent stones, they need a metabolic profile. It could be metabolic disease. We have come across patients coming with colic, we do calcium levels very high, when you do PTH high, do ultrasound neck, find count for parathyroid adenoma. Likewise, if your patient is a young patient coming with either recurrent stones or bilateral stones, they need metabolic screening. That is for investigations. Okay, any questions? Anyone? Can be. Sorry, I forgot. If it's a small stone, remember, sometimes you can cut it into the basket. The vesicular junction is not wide enough to pull the basket. Therefore, we tend to break the stone with laser, and the small particles are taken out using dominoes. Any questions? US කරන පාසල් මම හිතුවා this is one long case. One long case. Any question? This group. This group. What is the daily status of your viscous patient? How is she? Huh? Yes, sir.
CC.
From which department? Galua. Comes about. Any questions?